Good afternoon, students, and welcome to this module on transitioning from the hospital and acute care settings back into the community. We have a guest lecturer today, Angie Fawcett, and I'm going to share her slide set right now, and then she's going to introduce herself, and we're going to talk about her job and what she does in care management.
Thanks for having me. I'm excited to be here.
Me too. Thank you.
So I actually met Rebecca because the job I'm in now, she had, and I took that position. So she has really helped me a lot. So I've enjoyed that quite a bit, and everything I've ever known. Started out as a CNA in a nursing home, did a lot of dementia care, which I enjoyed quite a bit. Received my RN from the College of Eastern Utah in 2006. And I've done mostly home care and hospice case management. I did have a little bit of med surg mixed in there, which made me a much better nurse, by the way. I am certified in case management. I've been doing that with the United Mine Workers of America, which was really interesting. And then again, home care and hospice. I was a clinical director for a hospice company for the southern half of Utah for a little while. I did get my bachelor's from BYU, Idaho in 2019, which was neat. But currently I am a care manager for the Huntsman at Home Rural program, which is my dream job. I absolutely love it. So we'll be talking a little bit about what that is and what I do there, and just give you some of the experiences that I've had. And hopefully it helps you guys, even if it's not specific to what you guys are doing in your area. If it just makes you kind of think of some things that would be helpful, that would be ideal. That'd be great. Okay, so just to look at some considerations for social determinants of health, I really think care management is a lot about these things. So to talk about resources, when you think of transitions, we're thinking of them going from an inpatient setting to an outpatient setting. And so something that we see happen quite a bit is their functional status from before they went to a facility to when they get out can be quite a bit different. So their resources need to be different. And that's not something that we really anticipate happening, or the patient can anticipate, because they're just going through it as it happens. So we think a lot about home health and economic stability, but something else to think about is, so do they need to apply for Medicaid? A lot of times the hospital discharge planner or social work will start that process while they're in the hospital. And you may or may not get that message on discharge that that's been done, but what that will do is set them up for long-term in-home care, or if they need to go into a skilled nursing facility. It's definitely something you want to be aware of if they've had to change insurances or providers or anybody like that while they've been inpatient. It's going to change how we're taking care of them once they're home. So that's something that I think would be to pay close attention to. And if you could think to ask those things on discharge, it might make your life easier and save some time for the patient as well. Geography and distance. So in our area, if they're taken to a larger hospital, we're landlocked an hour in every direction. So they've got a little ways to get home. And so one thing I want you to think about is, are they coming home on oxygen now where they weren't before? Do they need new tanks? Do we need to have that set up at the house ready for them? Because depending on what setting you're in, when they get home, we might need to have equipment ready to go for them. There might be some things that you need to do on the outpatient side to be able to accept them successfully, to be able to go, that sets up your timetable a little bit faster. So those are things to think about too. And we'll talk a little bit more about how COVID's affected that in a couple slides. Culture. I think culture is really important, no matter where you are. Sometimes people go home to a home where they have a lot of extended family, big families. So there's lots of opportunities for caregivers and people to teach, and they're in a really great supported environment. Or sometimes they go to their senior living apartment where there's really no one, and they're not set up to have assistance and things like that. So I think it's important to know where they're discharging to, because that's going to affect how you're taking care of them. And I'll show you again in a slide or two some of the places I've done care in and how that affects how we're able to do care management in the outpatient setting as well. Socioeconomic status, very similar to what we talked about in the beginning. And then think about the neighborhood and where they are, what kind of care they have, how far are they from the hospital, how far are they from their providers. Transportation is a really big thing, especially in our rural area. We find that people have a really hard time getting to follow-up appointments. So that's something they'll kind of triage to the least important. And then they end up being hospitalized, or they're in the ER because they weren't able to make it to their next appointment. So let's see. one thing that I've tried to do is just holistically take care of people when they come out, and just kind of be aware of where they are. So if they went into the hospital and they had a fall and broke their hip, now maybe they're non-weight bearing for some reason. So that's really going to change how they're getting up to use the restroom. Do they have any stairs? So there's a lot of things that go into that. And that's where your interdisciplinary team is going to be really helpful to see what area they're going into. So you can go to the next slide. Creative spaces. I really like this slide. Believe it or not, these are all places I have done home visits. Now the fifth wheel is one I had to get off the internet, but I have done many visits in camp trailers. So let's start with the melon stand. That might be one of my favorites. This lady could not stop working. She was on a program that didn't make her be homebound, but she couldn't afford financially or even just like emotionally to stop working. She needed that interaction that she got, and she'd been selling melons for 30 plus years. This is just something that really helped her out. So I would go meet her at the melon stand, and when she had a break, there was an old laundromat. So we just step into the laundromat, we do our visit. She'd feel like she had enough support to get on the rest of the week, and we had things go that way. And so I felt like that was a really cool thing. I'd never done anything like that before, but we were able to have really good outcomes with her because it met kind of her personal needs that she had. And then we were able to, meet her needs in other ways. The tractor, believe it or not, I've had to meet farmers at the edge of their fields to check INRs and stuff like that. Nothing major, but if you know anything about farming, the harvest, and there's some things that just will not wait, no matter how sick you are. So sometimes you just have to be a little bit creative.
So you're meeting the patients where they're at sometimes, and not always in the places you would have imagined, but what's going to help them to adhere to the plan of care and not disrupt their life too greatly, I guess.
Absolutely. And with that comes, you'll have better outcomes, because if they're not hearing you can't farm or you can't do whatever brings in your financial livelihood, they're going to shut you out, and they're going to cancel visits or not show, or, there's going to be things that happen from that. So if you are working under a payer source or an insurance that doesn't make you be homebound, or there's circumstances, that's something to be aware of, then, trying to be creative in how you help take care of people really improves outcomes. And I've found that out the hard way.
I imagine you have a lot of stories about traversing out to these places with your kits and your nursing bag and whatever else you are and as a care manager, you talked a little bit about providing like INRs and things like that, labs, but like as a care manager, it's a little different because you're going out there to assess their situation and find out what are their barriers to care. Is that right?
Absolutely. And that brings us to a good point. So this fifth wheel that you see is a great example of that. So this gentleman, had respiratory issues, lung cancer. So when we go to see him in his home and he does not look good, there's no space for physical therapy to come in and really work with him. Showering is pretty limited. It's cold. It's the middle of winter. I'm wondering if his lines are going to freeze, how well he's going to be able to take care of his hygiene. But I also noticed he had a lot of pain. And so when we went in to see him, he was kind of looked a little bit overdosed on pain medication. He had a hard time staying awake. So I was able to go get Narcan from our health department and a smoke detector, because he'd also been smoking a cigarette and dropped it, started the newspaper on fire at his feet. And you could see he'd burned his hands from where he would try to put it out because he kind of dozed off. And so seeing those things, there's really not a job description that tells you what you should do. You just try to find what local resources you have. So we were able to get a smoke detector and some Narcan and take it out to his place. And then just trying to work with our interdisciplinary team. Okay, what does care look like for him in this setting, as long as he's safe? But there might be times where you go and you decide it's not safe. There may not be a safe setting for you to go to. And so we really need to think about what that looks like. And do we need to help them find something temporary, or let the doctor know so they can write appropriate orders? There's a lot to rehabbing in the home, because it's
right, especially if your home is in a fifth wheel or somewhere that doesn't have like proper, I don't know, electricity and whatnot. I've had that happen where they've gone to a home like that where they didn't even have electricity and they needed oxygen. So those are real barriers, but they're there. And how do you navigate through that as a care manager?
Absolutely. And you're hoping that if they live in that economic state, that maybe they'll meet Medicaid criteria, and then you have many more options at that point to get them some help, and maybe you lift them out of that cycle they've been in, right? Because of their living circumstances. But something else to think of with this gentleman in the fifth wheel, he'd lost so much weight. His BMI was really low, and it was exhausting for him just to even eat. And so just trying to think of, what does success look like? We worked with home care staff, and we were able to go get him a lot of protein drinks and things like that, things that wouldn't take up a lot of space in the trailer, things he didn't have to cook, and just what does success look like to him? And so we were able to make those things work. And then home care helped him get on the food bank application and things like that. So working as an interdisciplinary team with home cares or health departments or whoever it might be is really important.
Would you say that you're, as the care manager, overseeing a lot of this and trying to coordinate with home health, with the physicians? I mean, what's your role in this gentleman's life? What was your role?
Absolutely. And I think because this ended up being a patient that I was seeing through my work, so through the Huntsman, because we were the referring providers, we did act kind of like, if you think about like the quarterback, we were telling people, you go here and do this. And then we're tweaking plans in between there, connecting them with other resources, and just being kind of the central hub of where everything goes through, so that everybody doesn't work in their own individual silos. I really think it's important that people, work together, but understand what everybody else does, because a lot of different places might do something kind of similar. You can resource to later. So yeah, our job was just basically kind of overseeing how everybody did, getting feedback in real time, and then keeping the providers aware and making sure he could get to appointments and things like that, trying to prevent barriers from happening, anticipating them before they would happen. And so that was a really helpful situation working with those teams.
Shall I go to the next slide?
Yeah, let's go to resources. So in our rural area, there really aren't any specialists. We have a lot of primary care, but the specialists are going to be quite a bit further out, with the exception of orthopedic surgeons and things like that. So what you'll see is decreased follow-ups because they can't get there for one reason or another. And like I said earlier, that leads to disease exacerbations, ER visits. And it's just this revolving door of ER visits and hospitalizations. And if they have a chronic illness, they never seem to make it quite back up to their baseline. And so if we don't do something to kind of intervene, if we're not aware, right on hospital discharge or clinic discharge of what's going on with this patient, what the barriers are, this process will keep happening. So I think it's really important to know, where patients are, where appointments are, and what resources you have in that area, whether it's public transit, whether it's non-emergent medical transport, or you have to find something, because if you find it for one patient, it's going to be applicable to many. And that's something, that's really, really quite useful. Another thing too, is it's so taxing for them to travel to appointments. If they come out of the hospital and they're, short of breath and not feeling well, you wouldn't believe how many people will cancel appointments because they don't feel good. And it doesn't really make sense, because you're thinking this is when they would come, but there is obviously something that happens. People will cancel appointments because they just don't feel like going. They're not feeling well enough. And then you see they show up.
And I think from what I've learned as being in this clinical position is that it's really just, even for people who do feel well, trying to navigate appointments, go to those appointments, sit there, have whatever they're having, therapy or whatever they're doing. It's exhausting for somebody who is feeling okay. But so I can see that this is just takes a huge toll on our patients to have to, go back and forth between their setting of living at home to traveling long distances to appointments, and back and forth with the money cost, the emotional cost, the physical cost. It's great.
Something to think about too, if you were to follow up, if they have an outpatient physical therapy referral and you follow up to see how they're doing at that clinic and they have a couple cancellations, it might be really worth your time to say, hey, how about we do some home care physical therapy right at their home? So there's definitely things, and then you just go to the provider and ask for those orders, and you've really improved that patient's status at that point. So sometimes we don't know, or maybe they digress. They were okay to go to outpatient originally, and now they need to do, in home. So there's a lot of things we can do. Just because we get a set of orders on discharge, it's not always the set of orders we end up going off of, because once we assess them in the home, it looks quite a bit different.
Yeah, well, for sure. And that's brings up a good point, that what a patient looks like in the hospital setting, you have no clue about what that actually looks like in their home setting if you haven't been, especially to rural settings. Like if you haven't seen what rural life is like or what they are navigating at home, you imagine in your mind how this is going to work. And they're not necessarily telling you differently because they don't know what you're looking for. So, you're right. You need that expert pair of eyes at the home to help kind of paint that full picture of what this patient is going home to, or or what they're going to need when they get out of the hospital and go home.
Most people, if you think about it, on dischargers are anticipating being home so much that I think they underestimate how much work it'll be, maybe physically, emotionally, and on caregivers as well. They're just so excited to be out of the hospital. If they live far away, a lot of them are thinking, okay, is it rush hour? How is traffic? What does it look like? And all this time they're getting discharge teaching, right? They're being told how to take care of themselves. It'd be interesting to see like how much discharge teaching is really absorbed, because there's so much going on in their minds, that you might not see as an inpatient provider, that really limits what they understood from the discharge teaching when they get home. And I've seen that a lot. Another thing while we're on the subject is distance, so if you have someone that lives a long way away, so in this picture, this is my most southern visit that I do. It's on the edge of I-70. So it's about an hour and a half from our local hospital, which is several hours from their Huntsman place where they go to get treatments, right? But he also lives on like this 10-mile stretch of dirt road that's a private road. So if he has an acute situation, a stroke or a heart attack, and he hasn't plowed that road, how is the ambulance going to get out there to them? So, I mean, people, when they live in rural areas, there's advantages and disadvantages. So these are things to think about. If you have like an unstable patient, living in an area like this, we might want to ask ourselves, how do they get emergent care? What does that look like? Do they understand the risk? They're pretty isolated at that point too. It takes their family a long time to get there as well. And then do they have reliable transportation, to get there? I've seen a lot of care delay just because they have broke down vehicles or can't afford the gas. So we have a couple resources locally where they've done fundraisers to get gas cards and things like that. So it's really important, I think, to kind of know or anticipate where people can go to get these things. An example of somebody that managed to fall through almost every crack was, I go to a discharge planning meeting in our local hospital to see what the barriers are. And there was a gentleman that lived a couple hours south from where we were located. He had Colorado Medicaid. He needed to be discharged. There was no reason for him to be in the hospital. They needed those beds for other people. And because there's no public transportation, there's not really an Uber that would take him that far. He doesn't have any friends because he's several hours from home. And his Medicaid was out of state. Logistic care wouldn't take him. So we ran into almost every obstacle we could find trying to get him home. And so those things can be really hard, to be able to get people back to where they were. Another example is we had a patient, with COVID, a lot of these hospitals are on deferment. So we might have a patient from a rural area be flown out to Vegas, which happened not too long ago. They're there for several weeks. And then when it's time for them to come home, they're now on oxygen. Are they strong enough to make it's a several hour drive to get from Vegas to where we are? What does that look like? How many stops do they have to make along the way? And the biggest thing too is, do they have enough oxygen to get there? Because if they didn't go in the hospital on oxygen, the hospital will give you a tank to get home, but that's usually all the resource they have is a tank. And depending on how many liters you are, it's not going to last you more than a couple of hours. So it turns into this really big, like, coordinated event just to get someone home in these times if they've been flown out to faraway hospitals because of over and things like that. So definitely something to think about. And just a side note, like on our last hospitalization, we had 13% of the hospital beds were taken up by people they couldn't get discharged for transportation issues, which is huge.
Absolutely.
COVID.
Yeah. I can definitely second that. As an inpatient case manager, I was doing things like looking up how much is an Uber, or we have like different rides services, and trying to compare costs, and then trying to see if there's any charitable amount we can donate just to get a patient home to like Wyoming or to Nevada or wherever, because essentially they're not needing a hospital level of care, but they're not safe to just discharge locally to a hotel so they can find a ride home. So especially with our older adults, like I had an 80-year-old one time who had zero way to get back. So with insurance, Medicare and other insurances, they pay for that higher level of care transport to the hospital, but then it's no longer a medical necessity. So it's a social issue how they're going to get home. And that's really, you wouldn't think about that, but it's not under the job description. But looking up Greyhounds and Ubers and trying to navigate through like what types of ride services can offer, or even like flights, like, so because there's Angel Flight, for example. But all of these are very challenging parts about getting a patient safely back into their community, making sure that when they get there, they have someone to receive them and help them. If they didn't before, then what is that going to look like afterward? Yeah, I'd even safe to go home, like you said.
And I think too, looking up all those resources, it might be hard at first, but if you can figure out some reliable fixes to those issues, then you have a fix moving forward, which is nice. So sometimes it is, you just find those patients that just find the way to slip through every crack,
Yeah.
or you're just able to find ways to take care of them. And it's a lot more work than the patient ever realizes, or other care providers ever realizes going into it, is to get them safely from one place to another. It's a lot of effort. Another big thing that I have found is a big impact on how people heal is culture. So in our area, we're a very small area. We do a lot of coal mining. What happens, there's a certain time of year where they do something called a longwall move, and people will work 30 days straight without a day off. So if they've been hospitalized for something little and have a follow-up appointment, they are not going to show up if it's during that time of year. They're not going to be able to find time off, or they get laid off at the end of the year. That happens a lot too. So then they don't, there's a lot of things going on in their life if they're still of working age, or if their caregiver is still of working age, that's going to affect their care, their follow-up, their support system, all those things. So I think it's really important to kind of know what they're going home to, more than just the environment, but the support system.
And how much they're going to let you into their world. I noticed that when I was down in your area in Price and Moab areas, that I'm a bit of an outsider there. I'm not a local, and I don't understand the culture as well as you do living there. And I just kind of got the impression that these people are pretty stoic. They're pretty self-doers. They they don't always, and then a lot of times there's a trust thing. Like, do they really believe that I want, and I know what, not want, but know what's best for their care? I'm somebody coming in and telling them what to do, and they're looking at me like, you don't even get the half of what my life is like, right?
Yeah, it's hard. It's really challenging, and everybody's a little bit different. And like you said, a lot of people won't seek care for minor issues. They tough it out. They're very motivated by being able to get by financially, or whatever their
priority is.
Yeah. I have a patient, I wish I'd have included the picture, but he broke his leg, and him and his wife had to make up a bungee system to keep his leg elevated, because he had a full leg cast, but he had to bale hay. So he had this cast rigging done on his tractor, and he showed me a picture of it. And he was so excited that they came up with this, because he said, there's no reason I couldn't ride a tractor. I just had a broken leg. And I was like, that's really impressive, and he did just fine, but he was able to meet his needs, which made
these are pretty tough. Some of these people in these rural settings are very tough. Most people aren't going to think about going to work with a broken leg like that, but especially if it's like a job that requires you to have your legs intact.
Yeah, when you're self-employed or you're a farmer, there's no such thing as really a covering employee to take over your
right.
Day. So it's interesting. I've learned, like I said, I've learned a lot by mistakes too. So it's not like I know all these things. So we can go to the next slide, overcoming barriers to care. I really like, so the first one's knowing what resources you have. And I want to focus on the interdisciplinary team. So it's never just you as the care manager going out to take care of this patient. You need to think it like, I like to think of it as like everybody is part of a net that we're just weaving to be able to catch this patient. So you have home care, health department. We have something called active reentry, which we'll talk about in a minute, which I hope it's a federal program. So I hope it's everywhere. You have physical therapists, CNAs, primary care. I mean, there's so many people involved, but if you as their care manager can kind of get people lined out a little bit so they know how to take care of them, you create this really great network for this patient to succeed in. And then you're able to kind of anticipate needs and set up needs that they might have further down the road, so they continue to succeed when they're out of this acute exacerbation or whatever it is you're seeing them for. I really think part of our job is saying, okay, moving forward, you might want to apply for this, or this, this is going to be something you need in the future. Setting them up to succeed that way is so much easier than doing it in crisis mode. And people really appreciate, your anticipation of those things and helping them get, a lot of them don't know what benefits they have. They've never had to access them. They may not know what they cover. And that's another thing to think about as well. If they have, Medicare and the VA, depending on, we might want to get in touch with the VA and see what their benefits are. That's something that's going to really be helpful for them in the future. That's a great insurance to help keep people in the house for longer. And that's usually people's goal is to stay home, age at home and age in place. And so if they know that that's what's driving them, and they know that that's what their goal is, we're resourcing, we get a lot better outcomes, I think. So, and learning all those things, like I said, you really only have to learn once, what to look for, and then you've kind of got it down for the next one. So knowing what the patient goals are, I think we kind of talked about that a little bit. Some providers will do home visits for homebound patients, which I think is great. You'll have some patients that have like horrible bed sores that need to be seen. Now there is telemedicine that's nice, but it doesn't, like, you're not able to assess them and do all those things. So I think it's really good to kind of know as a care manager, is this person really able to get into the doctor's office and go? And if not, maybe we could make some arrangements to get some assessment data to that provider before they go. So this appointment really has more meaning than just, oh, you have a bed sore, I hear it's not good. Thinking about things like that as a care manager are really, really helpful. So programs, federal programs. So in our area, it's called active reentry. It's a federal program, so I imagine it's everywhere. But that is something as a care manager, I would figure out how to get access to them, because they can do so many things. They can help with DME, but they can also come up, like there's technologies they have to be very patient specific. So an example of this is we had a long-term bedbound patient that was very cognitively aware and with it, and had full use of her hands. She just couldn't walk. She was very weak, and full care in bed that way for weakness. But she started getting incredibly depressed because she just didn't feel useful. She had probably years to live based off her physical, health. It's just, she wasn't able to do much. And she really liked to sew, and she was, did quilts and all these things. So we went to active reentry, and they came out and visited her, and they came up with over bedside table that had a tilting tabletop with a sewing machine attached to it. And they were able to get like her, the foot pedal for the sewing machine to be able to done by hand. And it just had so many special things. And her outcome, like her emotional status, was so much better. Her husband was excited. He felt better about leaving her to go get groceries. And we didn't know that existed. Nothing like that had ever existed before. They made it for us based off what her needs were.
So when you say DME, you mean durable medical equipment. So that encompasses things like what?
So bedside tables, commodes, shower chairs, wheelchairs, walkers. But the special stuff, there's a I think she's kind of famous, barrel racer that had some paralysis. They made her a saddle that she can still compete.
So they customize to their physical functional needs. Like, and I know they do ramps too, right? They put
Absolutely.
in ramps.
They do ramps. They have transportation programs. So if you have like an adult that has cognitive issues with function, whether it be from stroke or vision or things like that, they can go in and help modify their home to keep them safe.
Especially, like, I've seen one of the biggest issues is split level entry homes. Like, whoever thought of a split level entry home? You have to either go up or you have to go down. And patients who no longer are able to navigate stairs, it's become a real problem. And if you want to put in like a chairlift, those are expensive. They're thousands of dollars. So no one has that necessarily option for them.
Patients don't answer their door when you go to see them because they can't get down the stairs.
Exactly. And so, understanding like what type of a home are they going home to, and how can a place like active reentry help resolve some of those problems so that they can go home?
Mm-hmm. And there's also like your areas of aging. So depending on the area of the state that you're in, that's also a government program. They have a lot of grants and things that you can do to get help for people. So geriatric patients have a lot of resources you may not realize they have. So just try to be aware of what's in your area. Again, so the last part is we just try to see them holistically so we can prevent them from coming back again. And I think that just kind of encompasses everything that we've talked about. One thing that I think would be really helpful is if, as the outpatient care manager, if you could get a copy of what their discharge teaching is, that is so helpful, because like we said, a lot of people aren't absorbing that when they're doing the teaching. They're thinking of so many other things, and we want to reinforce that. And you want to do it in a way that they've kind of already been taught, because hopefully it kind of cues them to think of other things. But just to give you an example, we had a patient that was discharged with abdominal mets to Moab, which is quite a ways away. she had a venting G tube and didn't understand necessarily how to use it. I'm sure she was taught in the hospital, and I'm sure she was taught quite well. But for whatever reason, when she got home, she had no idea how to use it. And so she was going to be going to the hospital for epigastric pain because she was in so much pain. So we ended up talking to the home care nurse about how to vent that G tube for her to relieve some of that pain. But it also gave the patient some control over their symptoms. So, she knew how to do that moving forward, which made her feel a little bit better about it, not just in the pain relief, but there was something she knew she could do about it, which I think is really important, because feeling out of control of your own health is a really helpless feeling that people have, and just giving them some empowerment that way helps a lot.
So it sounds like a lot of what you do is trying to prevent avoidable readmissions to the hospital by problem solving things in the home ahead of time.
Yes. And learning from hospitalizations. I really like to kind of pull cases apart of when someone was hospitalized to see what happened here, what can we learn from it. And older adults are living with a lot of comorbidities right now. You think of, in our area, COPD is a big one. So we have a lot of respiratory issues. So, in addition to what the acute exacerbation was for, let's say, their diabetes, we really want to make sure they're using their inhalers right and doing all these other things, especially when the air quality had been so poor this year. There's a lot of things to think about that may not be what's making them sick now, but if they don't understand, I think a lot of people with diabetes, maybe they get their initial teaching and then they've been diabetic for so long that they almost just don't even think about it. They just get in a routine for doing whatever they want or whatever has worked. But as that disease worsens and their sugars are more out of control or they need other medications, I really think that there's a time to re-intervene, and a care manager is a great person to recognize that and get those things going. For the chronic illnesses, I think care management for chronic illnesses is a huge help for people.
Definitely.
So lastly, next slide. I'd just like to talk to you about the scenario. Mr. James was not his real name, obviously. This is a patient that I feel like.
Go to which slide do you want? Sorry, I apologize. This one?
Okay. Mr. James, the scenario of Mr. James.
Oops. Let me pause this for 1 second. Okay, we had a technical glitch, but I'm going to share the last slide for you to talk about. Can you see your last slide, your case study?
Yeah. So this is a scenario of Mr. James. Obviously, that's not his name, but so this guy was a 64-year-old with multiple sclerosis. As you can see, a foot drop and altered gait. He was a VA patient, so not of Medicare age, so that affected how we were able to care for him and kind of so we couldn't just go to any Medicare provider, right, for orders and things like that. He lived 2.5 hours from his VA provider to get there, and so he couldn't drive. And he had monthly appointments because he had controlled substances for pain. So basically, as his condition got worse, he wasn't able to make it up to those monthly appointments. And because it wasn't able to go, he didn't have any pain medication. So for a while, he tried to tough it out. Tylenol, ibuprofen just wasn't working. So pretty soon he got a little bit more desperate and had to find other ways of managing his pain. In this case, it was marijuana. This went on for a few months. He felt like his symptoms were managed okay with where he was still trying to find a ride. He lived in an area that, was lower income. So it's hard to find friends that were able to afford to take him up there and had working vehicles as well. So months later, he was able to finally find a friend that was willing to take him the 2.5 hours. And he felt good enough to make the trip physically. As he got up there, the VA provider had to do his routine UA, and they found that he had been taking marijuana. Because of the policies at that time, they weren't able to continue providing him the pain medication, and for whatever reason, no longer providing care to this patient. So they weren't able to continue writing orders to the home care. So he ended up losing a 7-day CNA, 7-day-a-week CNA that would come every day, help him get breakfast, help him get showered, take care of his needs and things like that. He lost the nurse that would come in and do, his IV infusions and things like that. He lost basically everything because he couldn't find a ride. It was awful. He had PTSD from, fighting in the war that he had been in, had a lot of childhood traumas as well. And he wasn't really getting help for his mental health needs. And I'm sure some of that was he just didn't access it. But there were no mental health providers assigned to his case. I wasn't able to find anybody to keep him up there because of, the marijuana in his system. So the end result, he found people on the street, as he would say, to help take care of him and give him something a little stronger. the marijuana, and he ended up suffering a lot of falls and fractures, and he wasn't able to stay in his home as long as he wanted to. And I think what's so sad about the situation is all this happened because he couldn't find a ride, and so I personally feel like as care managers, there's a lot that we can do in these situations to try and help people, find things, or have even just, we have the time as care providers to do things a little bit differently than other places do because we don't have the same parameters. And so, maybe we can call these providers and say, listen, here's the situation of what's going on with Mr. James. What can we look at? Or this is what's been happening. So just know when he gets up there, you're going to find this, or, whatever it's going to be. How can we prevent situations like this from happening and having people lose all support over, something? And it wasn't the provider being malicious by any means. It was just the rules of where he was at that particular time. But is there a way we can work together around it?
Yeah, that's very heart-wrenching to hear that, and frustrating because, obviously he was self-medicating because he was in excruciating pain, and he was having unmanaged pain, and, not a lot of resources or support to help him through that. So.
Right.
Well, thank you for that. I'm going to stop sharing that, but I did have a few more questions just to ask you, Angie. So I wanted to make sure the class knew that you are a care manager in the rural setting, and you've been working for many years as a case manager, care manager, and a nurse in that area. And then also now you're a DNP student. So given that, how do you feel that your background experience in rural healthcare and as a care manager has maybe influenced your perceptions as a student, as a DNP student?
So now I try to think of myself like, if I was a provider, what would I expect from outpatient care? And it's really helped me understand a lot of the barriers that I think providers have in knowing resources and using them appropriately. One of my biggest passions is just connecting resources and creating networks for patients. But I feel like if primary care or providers aren't part of that, it's not going to be successful, because that's where the orders are coming from. That's who's really driving it in our healthcare system the way it is. And so I think, as care managers, if anyone is going on to be a provider of any kind or working with providers, this is such a helpful part of our healthcare system to learn, is to be a care manager, because it really improves the patients in ways that's not traditional. You're not a regular RN doing home care visits. You're not, a CNA or anything like that. You're seeing this situation a lot more differently from like an aerial view versus, down in there, which I think can be pretty helpful. Yeah,
I imagine so. And then throughout your experiences doing this, this profession, being in this profession, what would have been like maybe the most challenging situations that you've been in and entered into? What's most difficult about this type of profession for you?
So I think, the last scenario we had was probably one of my most heartbreaking situations, to sit and watch those things. But I think as we learn more, we're more empowered and more confident to say this needs to change, or we need to think about this differently. Developing relationships with people who look at things differently, and just learning from experiences that didn't go maybe the way we wanted them to go for whatever reason. We don't have a lot of control sometimes. But sometimes it's hard to watch people go without, or not rehab in the way that you hope that they could or would. And it's not for lack of them trying. It's all these other factors that influence their care that just aren't really looked at as often. Because I think as healthcare providers, we're very clinically minded, because there's so many things just within the clinical world that can go wrong. So it's hard just to keep everybody, kind of on the same page and involved in the case.
Yeah. So on the flip side, what's been the most enjoyable part of this job for you? What do you love about this, I guess?
So I do love this job. This is my favorite thing I've ever done. And what I like about it is just the freedom to do things, that I hadn't been able to do. So my background as a home care nurse, there was things, I could only go when there was a skilled need, and there were a lot of things you wish you could do, but there were certain things that held you back. As a care manager, I feel like we get to be a lot more creative. We don't have the constraints of, certain payers on us, like depending on what setting you're going to be working for. You can just be so much more creative and see this patient more holistically and stay with them longer, longer term than you could, if you were a home care nurse or something like that. If you're working, from a provider, from a provider's office, as a care manager, you're probably seeing that patient as long as they're a patient in that clinic. So you can stay with them long term and keep them going in the right direction. And as they need to reconnect with resources, you're able to do that pretty quickly because you know them. There's relationships there and there's trust that's built. And like I said, once you figure out a fix for a certain problem with a patient and then it comes along with another, you already know what you're going to be doing at that point. And it just feels really good. Like, I love overcoming barriers that, things that have been an issue or problematic. I love being with someone and brainstorming like ways to overcome. So I love the setting of an interdisciplinary team. It's so valuable to have those other viewpoints of people saying, well, we could try this, or when things aren't going well for someone, they're just not succeeding, having that team get together and say, okay, what are we doing? This is where we're at. This is where their goals are to be. What can we change to be better, instead of waiting to the end to see how it didn't work out? Yeah,
exactly. So lastly, what would, this class is a pretty interdisciplinary class. I'm glad you hit on that. And, some of the people in our class are moving on maybe to transitioning to new positions in healthcare eventually, or in academia. And I just want to know, like, what would be your advice to these students as they, transition into new roles? Even if it's not becoming a care manager, a geriatric care manager, what can they take from you and your expertise and from a class like this into their new role?
I think one of the most important things is to know your patients, know your communities, to be in touch with other resource places, to establish those relationships with other providers, other agencies, early on, learn a lot, and just be involved in community things. Whether it be, interdisciplinary meetings that they have, whether it's, healthcare fairs and things like that, just being connected as, whatever context you are as a provider, as a clinician. Having those relationships is going to benefit your patient and your practice so much, more than if we're just trying to, do things the way we've been doing them forever, the way, whoever did it before you. I think just being connected is really helpful. And that goes whether you're in a rural area or an urban area. It doesn't really matter where you are. Just knowing people, like, you and I have talked before that when you would be discharging someone and you knew that this company was going to take care of them because you knew who they were, you feel so much better about that referral and that patient's well.
Yeah, absolutely. The relationship that you've mentioned just now, forging those partnerships among the whole interdisciplinary team, from acute settings to the community settings, and just having those people that, you have personal, professional relationships with, that you've talked to them for hours over the phone over different scenarios and different, needs for our clients and our patients. And then just, developing a real sense of who they are and what their commitment is to this patient, and getting that kind of perspective of what they can offer really helps to smooth that transition of care, especially from, these tenuous situations in the hospital where, everything in this person's life has been rocked and changed. And then, what was their life before, they can't necessarily go back to living that way. And so finding, people in the community who are equally passionate about, making sure this person is taken care of. It's just such a great feeling to get to know these people on that level. It really helps you to feel like what you're doing is making a difference.
And I think too, coordinating with our inpatient counterparts is so important. If we have a patient we're familiar with and, we know that they're going to be inpatient or they've been admitted for whatever reason, calling that inpatient care coordinator and telling them what's going on, making their life easier. That also helps the patient as they're in the hospital. Maybe there's some things that they can only get done with a doctor's order while they're in the hospital, so I just think it's communication and coordination.
Yeah. And another thing I was going to lastly end on is that what impresses me about your job is that you are truly following patients long-term through, in and out of different settings, different treatments, different clinical appointments, hospitalizations, and then back to home again. And so you get to see kind of this whole trajectory of their care. And, unfortunately, sometimes you see the decline as well, but other times you have small wins where you actually get to, see a smile or a relief on their face when you're able to solve a problem that they haven't been able to solve before, because you cared enough to actually go that extra mile and be creative and connect them to other resources. And that's the beauty of your job, I think, is that you get to be that person who is a problem solver and a detective, and you have to be creative, and you have to do things that may never have been in a job description. But I think that's what you've told us that you love about this job, is that you have that kind of liberty to work across all of those disciplines in the community.
Just advocating, I think, is one of the biggest things that we do, whether it's for themselves to be, more knowledgeable. And I always would hope that patients are more knowledgeable when we're involved with them than if we weren't, right? Because the healthcare system can be pretty complicated. When you go from, private insurance to Medicare to Medicaid to retirement and things like that, there's so many different barriers and benefits that come with those things that they may not know they have, so advocating, I think, is huge.
Is there anything lastly that you want to leave us with? Or I think we've covered a great amount of topics in a short amount of time. And I think we could talk for hours about this, you and I, as we have many times in the past.
I hope that you just understand this is such an incredible opportunity to care for these people, especially the geriatric community. It's a wonderful job, and you can make it be whatever you want it to be. And it's something that I absolutely love. And I hope that showed today. Thank you for having me. I really appreciate it.
Thank you. I'm going to stop our recording now.